let's take the case of a patient who has been on alectinib Alecensa for ALK positive metastatic disease, presented with brain metastases that were without symptoms, and over that course of treatment developed 3 brain metastases that needed to be treated, but then did well. Eventually, after 3 years, progresses in the body, but not in the brain. How concerned are you that you would need to continue an ALK inhibitor just to cover the risk in the brain, in terms of this is somebody who has had initial brain metastases, then progressed transiently on alectinib? So my question is basically, when you have a patient where you're concerned you're going to need to switch to chemo, would you consider concurrent ALK inhibitor just to control the brain as well? Or at some point, do you just have to abandon worrying about intracranial brain control and put it all on the chemotherapy at that point?
So in terms of maintaining CNS control, that's really critical in ALK lung cancer, as we talked about before.
CNS being central nervous system or brain.
And first line, alectinib really help, the CNS benefit, the central nervous system brain benefit really helps drive that progression-free survival. When they progress on that, I think the short answer is it depends. I think like most things, with patients going to go on chemo with carboplatin pemetrexed is a very good drug across the blood-brain barrier. Okay. So I think in situations like that, you don't necessarily need to continue the ALK inhibitor.
Can I just interject by asking you, when we use pemetrexed, Alimta a lot in lung adenocarcinomas, very good drug, and maybe preferentially favorable in ALK positive. Are you talking about using it as a single agent or as a combination?
I would, in a patient who hasn't had chemotherapy, I would typically use it in a combination, like with carboplatin and pemetrexed, and then sometimes with bevacizumab as well. There's a suggestion that Avastin, the younger patients may, especially these oncogene-driven tumors, may be more sensitive. Tumors may be more sensitive to this, the VEGF inhibition, strangling the blood vessels that feed the cancer. I would just highlight that, the Keynote 189 study that looked at carboplatin, pemetrexed, pembrolizumab, Keytruda, did not look at ALK patients, did not look at EGFR patients. So I generally, if I'm going to do carboplatin, pemetrexed, I generally do not add the immunotherapy.
So, Suki, what are your thoughts about how much do you worry about and factor in risk in the brain at the time that you're thinking about transitioning to a chemo-based approach?
I factor it in a lot. So I think if a patient has had only body progression without brain progression on Alecensa, and they have a history of brain metastases, but they're super well controlled, I would be very nervous to abandon Alecensa. It's kind of a similar principle that we're seeing in other types of lung cancer, EGFR mutated, for example, where we're thinking about continuing osimertinib at the time of progression for patients who have a history of brain metastases but are progressing in the body. Right. So I think this question is applicable to a lot of types of lung cancer where we have good oral drugs with brain penetration that control the brain, but with,
It's very frustrating because we don't have combination data to speak of, but the concept, the rationale is very strong for this. And so I think that many of us are inclined to cobble it together or at least think about it seriously, but we need data to speak to this.
I think that's absolutely true. There's not really published data or presented data. But the one thing we do have to think about when we're combining a targeted therapy with then chemotherapy is about safety. So we just have to be mindful of that too.
I would just highlight that, in patients with ALK lung cancer who haven't had brain mets from the start, I'm still very vigilant about checking for brain mets. So, normally at the time of progression, I, typically for my non-small cell lung cancer patients, get a brain MRI as well with systemic progression to see if it's also spread to the brain. But aside from that, even if things haven't progressed systemically, if they're on Alecensa, every 6 months or so, I will get a brain MRI. I don't know if that's your practice as well.
Yeah, for me, it depends a little bit on how good the drug is at crossing into the brain. If a patient doesn't have a history of brain metastases and the drug is very well known, like Alecensa, to get into the brain, I may do annual surveillance. And then, of course, anytime you see body progression, you need to check the brain.
I agree with that, if you have a patient without brain metastases and have them on an agent that is very good in controlling within the brain, I think that would lower my suspicion. Not to say never look, but I don't know that we need to look every few months when the pretest probability, the probability of finding progression is very low in the absence of new symptoms. Of course, if someone has new brain headache or vision changes, that would change everything. But and as would progression in the body, raise the probability of something. So it's always worth looking in that setting.